data-driven care is the only way to deliver care. If you're going to deliver quality care, you have to continue to measure what you're doing, how you're doing it, and how effective it is. Otherwise, not only could you stagnate at a certain level of quality, but I think you could actually get worse at it.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. My guest today is Dr. Khalil Sivjee, Medical Director at Cleveland Clinic Canada and a pulmonary critical care physician who's turned bedside frustrations into system-level fixes. Trained at Brown, University of Connecticut, Yale, where he served as chief medical resident, and Weill Cornell, Khalil learned early how smart data can shorten suffering. First at Kaiser Permanente and later in Toronto, where he led respirology at Sunnybrook Health Sciences Centre, taught at the University of Toronto, and built programs that moved patients faster from worry to treatment. Today, he's pairing that ethos with new care models, metrics that matter dashboards, EMR flags that catch weights before they snowball, and embedded near-work, near-home clinics that make prevention practical for busy people. He also serves as Chief Medical Director for the Royal Bank of Canada, advising on healthier workplaces and upstream screening that spots hypertension, diabetes, and mental health needs before they become emergencies. He's a fellow of the Royal College of Physicians and Surgeons of Canada and the American College of Chest Physicians. Active with the Ontario Medical Association and American Thoracic Society. And when he's not rewiring care pathways, you'll find him on the tennis court, a golf green, or cheering on his beloved Yukon Huskies. Dr. Sivjee, Khalil, welcome to the show.
Thank you, Jason.
So we've known each other for a little while, but even just before hitting record, having a bit of a dialogue about some of our respective backgrounds. And I wanted to dive a little more into yours. You've had an interesting career path, as I alluded to, both from in the US and Canada. When did quality and patient experience first click for you? Was that earlier in your training? Did that come later after you were an attending?
Yeah, it probably wasn't a single event that where something clicked and I became interested in quality. It was through a series of observations throughout my career where I just looked at the way something was done. And when I asked why it was being done that way or why we couldn't do it a more efficient or a safer way, I never got a clear response to that. It was always kind of, this is the way we do it. I think my absolute first episode of that was when I was working as a staff attending in California in the ICU. And we would have patients that were intubated. And some of our patients were covered by intensivists who were there all day, every day, all night, every night. And then we had a few patients who were rounded on by community-based docs. And those docs would come in after their busy clinic, 3 o'clock, 4 o'clock, 5 o'clock in the evening, make a slight adjustment to the ventilator, and then leave. And nothing would happen until 24 hours later when they came back. And sometimes on the weekends, it would be longer than 24 hours before they came back. So these patients were obviously on these ventilators for longer periods of times than the patients that were covered by the intensivists on site. And so I asked, why is that? Well, why aren't these changes made either by myself or by other critical care docs that happen to be there? And the answer I got was, that's the way it is. And so we developed a liberation protocol from the ventilator, a ventilation liberation protocol. And I proposed it to the docs that were based in the community who surprisingly had no problem with it. They were like, sure, I mean, you're actually helping us. And we got it approved. And I worked for a large healthcare organization in Southern California at the time and got it through the appropriate committees. And we launched this thing. And all of a sudden, we measured a difference in how fast people were liberated from the ventilator. And that was sort of the first light bulb that went off that said, wow, someone who is a junior staff can make an impact like that. I wonder what else is out there. And so every other step during my career, I just kept looking for these opportunities where small changes could have huge impact. And they were essentially resource neutral. It's just taking what you have, rearranging it, and getting better outcomes.
Yeah, I think so many of us in the quality improvement space who have found our way here one way or another have had those kind of light bulb moments as you describe. One thing that's exciting about this and these types of conversations for me is to kind of show others who haven't yet had that light bulb moment or at different stages in their QI path to realize that, as you said, a junior staff member can be really impactful. That people can often be brought around to good ideas if they're presented well and if we've navigated the change management landscape effectively. But that's really powerful. So you mentioned, working in Southern California, and I think you were working for Kaiser at the time, if I recall correctly.
That's correct.
What did you learn about integrated data-driven care when you were practicing there, or how has that become a prominent theme for you since working there?
Yeah, I've come to appreciate that data-driven care is the only way to deliver care. If you're going to deliver quality care, you have to continue to measure what you're doing, how you're doing it, and how effective it is. Otherwise, not only could you stagnate at a certain level of quality, but I think you could actually get worse at it. One example that I had when I first joined the current hospital system that I'm in now in Toronto was our lung cancer data. And so we would look at patients who came in with a suspicious lung nodule, and they would come to see us. So they'd wait to see the pulmonologist or respirologist, as we call it in Canada. And that wait might be days to weeks, at which point we then see them, of course, do a complete history and physical, look at the x-ray, order a CT, wait number two. Once the CT was done and interpreted, they'd come back and see us. We decide, do we do a bronchoscopy? Do we do a CT guided needle biopsy? Do we do a PET scan? What's the next step? Wait number three. And eventually we would have histology. We'd prove they have lung cancer and we'd send them to the thoracic surgeon or the radiation oncologist or the next appropriate specialist. And when you added up these sequential waits, it became months of waiting. And we know now that, in fact, lung cancer can upstage in as little as 2 to 3 weeks. And so as we got busier and busier, these waits just got higher and higher. And there was no way I could just sit and watch that happen. And that was one of the times where I said, okay, we've got to change this entire system. Again, completely resource neutral. It was just about realigning what you ordered and when you ordered it. So the second that referral came in for a suspicious nodule, I had already ordered the CAT scan. I had ordered the CT guided needle biopsy. I had ordered the referral to an oncologist. I could always cancel those if I didn't need them, but we showed that changed our time to treat lung cancer from about 6 months, which was really hard for me to believe, down to less than 90 days, which still is a long time, and it still could be an upstage, but it was a step in the right direction. And from then, I was convinced that data-driven care not only is an intelligent thing to do, but it could change people's lives. And it was the only way I was going to practice going forward.
Yeah, I do wonder, actually. First of all, I'm fully bought into that approach. You really can't affect what you can't measure. And this is something that I feel like I spend a lot of time preaching. And I'm curious if you've noticed differences in different places you've practiced, whether it be different parts of the US or the change over to Canada, if there was different approaches or different willingness to really take a data first approach.
Yeah. I think that in the end, at least in North America, we all got into this profession for the right reason, which is to help people and to make sure that the care that we deliver is the best care that can be delivered. And I think that transcends borders. I think it transcends cultures. I think it transcends economic systems as well. And maybe I've just been lucky, but I've found that any time that I come across a system of operations that I think could be more efficient or working well, and then introduced a concept of how to change it to make it more efficient and more patient-centered and more effective, that I have been met with actually very little resistance. The only exception to that, I would say, is and it was not in my current job. It was in a prior job, and it wasn't with Kaiser. So I'm going to take them off the table here for a second. but it was in a place I was moonlighting actually, and I was seeing pulmonary consults to try to decompress their wait list. And I would walk in, and there would be a couple of consults in a fax folder for me to look through and decide who I was going to schedule to see. But then there would be two other fax folders with other physicians' names on them, and I said, "Well, what's in those? I wonder if there's any urgent consults in those." And the answer I got back was, "Well, Doctor," and I'll use a fake name here, "Dr. Jones is on vacation for 2 weeks. That's his pile." And I said, "But what if there's this lung nodule in that pile? What if I've, coughed up some bloodstreak sputum in that pile?" And the answer I got was, "Well, Dr. Jones will get to it when he gets back." And that sort of profession-centered organization of medicine in the community setting sometimes is a little bit hard to get over. Of course, when Dr. Jones did get back, I said, "Hey, I wonder if we should have a central triaging system such that there is a Dr. Jones pile and there is a Dr. Sivjee pile, but there's also an urgent pile where someone with very few rules to follow could identify what sounds like urgent consults, put them in an urgent pile, and the next person that got to that pile saw those patients, not the person waiting to come back from vacation in 2 weeks." A little bit of resistance. Obviously, that's fee for service. You eat what you kill kind of thing, and you have to make sure that the number of referrals you get is sufficient to sustain your practice. But I think with enough time and with enough open discussion, we were able to get through that. In fact, we did have an urgent consult pile in the end.
Yeah, that's great. And I'm sure that was impactful. Were you able to measure any metrics in terms of the turnaround there?
Yeah, so I was a pulmonary fellow at the time. I didn't want to
Sorry, I set you up for that one.
rattle the cage too much, and so I was satisfied with the fact that we had an urgent care pile. I did not delve into what the actual numbers were.
Fair enough. And then, your career saw you in 2005 relocating to Toronto. And so I think the cross-border moves, although they're becoming, I think, a lot more frequent, are still, you're still in a pretty small group of people. I'm curious what inspired that transition, how that went, and where you find yourself now.
I had a knack for leadership even as a young kid, and it wasn't actually because I sought it out, nor was it because I was appointed such. And I came to this realization actually in Little League, where I was never captain of my Little League team, but I showed up on time. I went through all the drills the way I was supposed to, and every day I gave it my all. And at the end of my last season, the coach came up to me, and his son was on the team and was actually the captain every year I was there. But he came up to me privately. He said, although my son, and I'll say his name, although my son Sean has been the captain, wore the C on his jersey, you've been the captain of this team. You've led this team." And I said, "What do you mean by that?" He says, "You led by example. You led because you worked hard. You showed up every day. And you gave it your all." And so that struck a chord with me. And I realized that, leadership sometimes chooses you. And so when I went through fellowship and I graduated, I knew that I was going to eventually climb the leadership ladder. When I was with Kaiser Permanente, I was being groomed to go through their leadership process. But sometimes if you have the opportunity to skip a couple rungs on ladders, you do that. And in 2005, I was given that opportunity. The University of Toronto has 4 teaching hospitals. Sunnybrook Health Science Center is one of them. And the opportunity came up for me to be the division head there in respirology, which was a couple of rungs of the ladder up from where I was with Kaiser. I'm also from the northeast of the United States, and Toronto was a great place to be and much closer to quote unquote home. So that factored in as well. But that's that's why I made the decision, and it was a great one to make.
Yeah, and I think there's probably a lot that we could dive into there in your time at Sunnybrook and beyond. But taking another step or two ahead, you actually gave facilitated a great lecture with one of your colleagues, Heather, at our CQO community, a community of quality leaders that has been convening every month for a few years now. And it was talking a lot about how so your practice now is based out of Cleveland Clinic, Canada, and you're a unique organization, as I understand it, in that you are solely outpatient focused, in contrast to the way the the model works in the US with the Cleveland Clinic, I think, being both inpatient and outpatient.
Yeah.
Your presentation recently was about your efforts towards using metrics that matter and how you measure quality in the outpatient setting. So I'm wondering if you can tell me a little bit about that work specifically.
Yeah, sure. So you're absolutely correct. Cleveland Clinic Canada, which has been around for 20 years, is based in two ambulatory clinics in downtown Toronto and midtown Toronto, although we have a virtual presence and we have affiliate clinics throughout Canada, as opposed to the Cleveland Clinic in Northeast Ohio, which has dozens of buildings and inpatient beds, and they're also in Florida and Las Vegas and Abu Dhabi and London. But we're unique in the fact that we don't have hospital beds, and that is simply a function of what we are focused on, number one, and number two, because as you know, in a universal healthcare system, the government owns and runs the hospitals. Having said that, there is a focus on the patient and being driven by patients' needs and delivering patient-centered care. So the emphasis on the patient experience, I would argue, is equal in our Toronto/Canada offices as it is on main campus. And just because you are being treated for a urinary tract infection in Toronto and maybe not on IV antibiotics in a hospital bed for urosepsis doesn't mean that we can ignore your experience. And the patient experience is really important. So how we handle you when you come in, when we see you, so access to our care, how we make sure that you don't have a drug allergy to the antibiotic we're going to use, how we follow you up, how we answer your questions, how we let you know that your urine culture showed a certain E. coli that is sensitive to the antibiotic that we gave you, how we handle the adverse reaction to the antibiotic. All of that is, I think, important, not just in terms of patient experience, but also in terms of quality and safety. And so we have an emphasis on that. And the colleague you were referencing earlier in your question, Heather, is our senior director of the patient experience. And so her and I meet on a regular basis. She reports to me the Press Ganey responses from all of our service lines, and I won't go through them all, but we have 7 total service lines. We also go through our safety event reporting data. We look at our root cause analysis we're done. We look at process improvement that's occurred in the clinic. And we look at those metrics that matter that you referenced. So things like how long did it take for our diagnostic imaging to turn around? Because that matters. When you have a mammogram, not that I've had mammogram, but you can imagine if you've had a mammogram and you're waiting for those results, you're staring at the ceiling for those nights. And the difference between 7 days and 3 days in terms of a turnaround time is massive. It may not impact the overall outcome, especially if it's a negative mammogram. But, a week staring at the ceiling, wondering if you have breast cancer because your aunt just was diagnosed with breast cancer is super impactful, and I believe matters.
Yeah, and I'm seeing an interesting contrast there between what you just described, which sounds like a very patient-centered viewpoint, to the kind of the more physician or staff-centered models that we sometimes see and that you were kind of mentioning before. That absolutely makes a difference. And we hear that on the front lines. We hear people saying, why hasn't this test or that test resulted yet when it's been 7 days and could reasonably be done faster than that? So how do you approach measurement, making sure that these metrics matter, how you choose kind of which metrics you use, and how is it different between the outpatient world and the inpatient world? Because I think a lot of us in healthcare QI are inpatient people.
So that term about waiting for your scan to turn around, I've heard it called scanxiety. But anyways, so we try to limit scanxiety and other anxieties really by asking ourselves, if we were the patient, and you have to be reasonable, of course. You can't wish that your scan was read yesterday if it was done today. That's not going to be reality. But we say, if we were a patient, we ask ourselves a question like, if we were to pick up the phone and want to make an appointment, and I'll just pick on mammography because that's kind of a hot button topic now, especially in the province of Ontario, where they've switched to a self-referral model, so you don't need a referral to get a mammography. But if you were a patient and your aunt was just diagnosed with breast cancer and you were in your 40s and you want to schedule your mammography, what would be a reasonable amount of time you would want to wait for that? And then we look at and try to benchmark that against other wait times, both locally, provincially, nationally, and internationally, and come up with a number. So that's one thing that we do. Then we look at turnaround times for things like mammography, of course, other diagnostic imaging, stress tests, echo, path reports, and again, benchmark it against local, but not just local, also provincial, national, international averages. And we try to beat all those. We try to say, okay, that's the average. We're going to be better than that. Is that good enough? It's a start. And if we could offer same day service for every service we have, we would absolutely do that. But at least we have a North Star. At least we have a metric that or a measure that we're trying to get to, and always asking ourselves, can we do better? Is there a better way of serving the person so that they have the least amount of anxiety while they're waiting for tests to get done, consults to be seen, results to be reported back to them? I want to piggyback on something you said about profession-centric versus patient-centric care. That's been a pillar of the Cleveland Clinic since its inception. So 104 years ago, the Cleveland Clinic in Ohio was started by four physicians who actually were practicing in World War I. And they were in a MASH tent together, and the patient was in the center, and they brought services to that patient. When they went back in 1921 to Northeast Ohio, they said, that worked really well. We should get rid of our offices and start the Cleveland Clinic. And in fact, unlike other health systems, there is no Department of Medicine, Department of Surgery, Department of Neurology at the Cleveland Clinic. There are only institutes around patient care. So there's the Institute of Digestive Diseases, where you might have colorectal surgeons and gastroenterologists and nutritionists and psychiatrists and immunologists all working together. Again, that MASH tent, patient in the center, bring the services to the patient. That concept has pervaded throughout all the Cleveland Clinic sites that I mentioned earlier. And it's also the motive we use in Canada as well.
Yeah, thanks for clarifying that. It sounds like a really revolutionary model. I'm curious, when you're talking about, measuring metrics that matter, when you're talking about, for example, mammogram turnaround times, I'm imagining each step in that process. If you're mapping that process, each step has a reasonable amount of time that it takes to complete, and then there's a waiting between step A and step B. And then step B has a certain amount of time to complete, and then you've got a waiting time or some other delay between B and C. When you're all looking at these processes and looking to improve them, are you getting down to that level of granularity? And I ask that partly because I think you talked about being resource neutral, cost neutral. One of the challenges can sometimes be having the staff and the expertise kind of all in the same room to be able to map processes down to that level of granularity. Is that part of the conversation?
Yeah. I say resource neutral because I consider patient experience and quality lead as part of that necessary part of the care delivery pathway. And so the answer to your question is yes, we do look at we've got patient flow maps for almost every type of encounter that someone would interface with us. And we've once you've established them, they don't change much, and it's just a matter of figuring out where these aggregate wait times fall and how long they are. And then you set up automated systems such that when the wait time exceeds, and when we use an electronic health record like most everyone else does now, and we've built in systems so that the electronic health record can flag when those wait times exceed what we'd like them to be. So if I know that pulmonary consults are now 9 weeks, and I've said, no, they must be less than 4, the EMR will actually say, hey, red flag, you're booking 9 weeks out. You wanted me to tell you when you were booking more than 4 weeks out. And so, yeah, the first time down the hill in the sled is going to be a little tough and require some investment. But after that, when you automate these systems, they serve you well.
And that's another really interesting hill that it sounds like you've successfully climbed. I know some institutions will struggle with, which is, once we have a new process, a new policy in place, how do we measure when the system is in spec or out of spec? And it sounds like you've got some real metrics that are tied to your EMR that can do that. So that's, I can imagine that's a huge benefit to keeping on track once you've got those processes mapped. this sounds like really important stuff when it comes to using metrics that actually matter in the outpatient setting. And I wanted to hear a little more about another area where you're, I think, innovating in outpatient work, and that's your role as the chief medical director at the Royal Bank of Canada, RBC. Because I understand that you're trying to bring a lot of these kind of whole patient wellness principles, maybe traditional and some also innovative principles to the corporate workplace. I'm curious what you can tell me about that whole model.
Yeah. So that's correct. I am the chief medical director for RBC Royal Bank, but it's through a contract that they have with the Cleveland Clinic. And there's a service line that we have called Global Corporate Advisory Services. And this really grew. It started before COVID, but it really grew once COVID was in its full blown stages. And I think it's born from the realization that people spend a lot of time at work. They probably spend a third of their lives in the office. And while they're there, they're exposed to a bunch of different things. They're exposed to the commute to the workplace. They're exposed to their desk space and their office space and the ventilation and the quality of the air in that ventilation, perhaps some of the radiation that's emitted in the workplace. They're exposed to sunlight, or sometimes not if they're working in a building with no windows. They're exposed to printer ink, although that's becoming less of an issue. They're exposed to the building itself, what's in the walls and things like that. So, and then they're exposed to the nature of the work with all its inherent stresses and whatnot. And so companies started to realize that if they were going to have a resilient and dedicated workforce that showed up, was present, and thrived at work, they have to be at least aware of what makes a healthy workplace and what makes a healthy workforce. And so we've been helping both the Royal Bank and now dozens of other companies address issues that affect the health and well-being of their workforce and not just of individuals. So that might be things like letting them know about ergonomics and teaching them how you should, every 20 minutes you should be looking up from your screen and looking 20 feet away so you don't get changes to your vision from staring at the screen all day. It might be looking at their buildings that are more than 60 years old and saying, is there asbestos in the walls, and what working with their corporate real estate groups and advising on that. It might be air quality, and unfortunately, as you know, with climate change, we're having more and more forest fires, and in Toronto at least, the air is not such great quality every few weeks. It's sometimes orange when you walk outside, and part of that is from forest fires from the prairies. And so, what's the impact of that when you have a part of your workforce that has chronic lung diseases like asthma or COPD? What should you advise people? How should they monitor air health quality indices? So that's been a really interesting part of my career. I've learned a lot of occupational medicine. I've learned about a lot of things about buildings and building materials that I never thought I would ever learn about. Certainly didn't learn about that at medical school. But these are things that can significantly impact the health and well-being of people that work in those buildings.
Yeah, I felt myself needing to adjust my my posture
Yeah,
in my chair as
that's
you were
right.
talking about
That's
ergonomics.
right.
I'm sure you noticed, and I certainly hear that. I mean, it sounds like this was, in the circuitous pathways that our careers sometimes follow. It sounds like this has been one area where, again, you've learned about buildings and air quality, some of these things which kind of touch to respirology/pulmonology, but also probably a whole lot of other areas. And so this model, it sounds like, is advising companies on a lot of the aspects you talked about. Is there also like direct provision of medical care?
Yeah, so it's an interesting question. In its original concept 10 years ago, I've been the medical director for Royal Bank. Actually, today is my 10-year anniversary.
Happy anniversary.
Thank you. The original concept did not have any direct patient care. It was mostly being the bridge between their human resource department, their benefits department, and their senior leadership. Because often there's a little bit of a disconnect between those. if a new medication comes out, they're deciding whether it should be on the formulary. Well, there's a cost to that, obviously, and the senior leadership team may not be able to or want to incur that cost this year, and employee relations has to deal with the fallout from that decision. And so I would come in and bridge those two. So that was the original concept. However, because we're having such a primary care access problem, and this is not unique to Canada, I've talked to my friends back in the States, and it is a North American problem, if not a global problem. We've got lots of aging people with chronic medical conditions, and we have fewer and fewer family doctors to take care of them. Because of that, we've had to come up with some unique ways of offering at least the basic foundational primary care to groups of patients. So, for instance, there's a delivery company, I won't go into details, that had all of their 1,000 employees in their main warehouse. And we went by and we did some health screening, some basic health screening for them. Point of care blood pressure testing, point of care cholesterol screening, hemoglobin A1C, checking for diabetes. We measured their waist circumference, and at least we gave them a scorecard at the end for those 1,000 employees to say, okay, here's the subset of you that really should go on to connecting or reconnecting with your family doctors and taking care of these things before they become a problem. And, we included some mental health stuff in there as well. And, with the PHQ-9, obviously these were nurses that were in private booths that were working with these folks, but we were able to offer some, I don't even know if I'd call it primary care, I'd call it maybe pre-primary care to this group of employees sponsored by their employer, who all of a sudden, instead of having to take the half day off to go see their doctor if they could get in, at the workplace had this foundational information about their health and could start working on that. We picked up brand new diabetics. We picked up people in stage 2 hypertension that needed to get that addressed fairly quickly. And it was really, really fruitful. And other companies have looked at that model and said, okay, well, maybe that's a way for us to contribute to our employees' health and well-being, and maybe even decompress the public healthcare system a little bit.
And it sounds like something that I've heard kind of more and more about, which is how do we innovate in things that are care that's upstream from the hospital experience, right? We spend a whole lot of time focusing on the hospital, and for good reason. And at the same time, we have fewer and fewer family docs, as you say, trying to care for more and more people in more and more distanced communities. And so how do you innovate to create new models where some of these people can be met where they are in a truly patient-centered way? And I understand also that one of the other initiatives, so this big initiative has been this TytoCare initiative. Tell me about TytoCare. What's that all about?
So TytoCare is a company that developed, I would say, user-friendly diagnostic equipment, and it can be done by a layperson. It can include many things, but at its very core includes an flexible otoscope to look in the ears, a rhinoscope to look in the nose, a laryngoscope to look in the mouth, a blood pressure cuff, a stethoscope. It can include even a 3-lead ECG and a pulse oximeter, depending on what level of TytoCare you get. But it's essentially a self-diagnostic, self-examination tool that can be placed anywhere and used by almost anyone. I think we even had it down to like the 3rd grade level could learn how to use this. And we have gone to places where it's been either convenient for people to use this tool, upload that information either synchronously or asynchronously, and then connect with a healthcare provider virtually. And so we've placed these in university campuses where students maybe you want to go get a checkup at 2 a.m. because that's when you're done studying, right? And all the pizza places are closed by then. Well, you can do that now, right? We've placed these on First Nation reserves where access to care, as you know, is very challenging. We've placed this in mining company towns where there'll be this remote area where 5,000 employees are congregated because they're on a mining job site and they have no access to healthcare, and it's 3 hours to the closest. Can you imagine that? Imagine wanting to get a checkup, to get your blood pressure checked. You leave your work, you drive 3 hours, You probably wait in a waiting room for a bit, get your blood pressure and whatnot checked, and then go back to work. Well, that's your whole day is gone. The productivity loss from that is immense, multiplied by 5,000 employees. We can put a TytoCare clinic in that setting, connect with the nurse practitioners, and of course, once in a while, we'll send out sometimes physicians, sometimes PAs, physician assistants, sometimes nurse practitioners, to see any patients that need to be seen in person. But the efficiency of that and the access that offers compared to what they have now is like night and day, right? The one thing I didn't mention, and I assume you were going to ask me this question, but I'll just prompt you anyways, is who is interpreting that data? And so far, it's just been one-to-one. You get your blood pressure on Tyto, and I have to look at your blood pressure and decide if you have hypertension. Well, as you know, you don't necessarily need a physician to decide that anymore. AI can decide that, right? So we are looking at, especially with the dermatoscope, which I didn't mention. When you put a dermatoscope on a rash, let's say, your local family doctor might have seen that rash 500 times. I'm just pulling that number out of thin air. Maybe your dermatologist has seen that rash 2,000 times. Well, Google Images has seen that rash 5 million times, right? And I think it's only a matter of time before artificial intelligence and deep learning is able to not just take that data that you're uploading through your own self-examined experience with TytoCare, but also interpret it correctly and give you a little bit of a sense of this is urgent, you must go see someone now about this, or try a little steroid cream and you'll be okay.
So it sounds like between examining the skin, examining the mouth and throat, the ears, the blood pressure, there's a whole lot that you can do
there's a
with
stethoscope
very few
as well.
resources. Stethoscope as well.
Yeah.
And so the 3-lead ECG as well. So there's a lot that you can do. And it sounds like with very few resources other than this product itself and maybe some kind of designated, area. Does it involve a lot of cleaning or maintenance of this equipment, or is that?
Well, we've been using this for about 4 years now. The results have been excellent. We've had very few. In fact, we're going to be writing this up fairly soon. Very few user errors, critical errors, where we're not able to get the person to get the information. The cleaning is self-explanatory, and it's done after each use. And this is like hard plastic, easy stuff to clean. It's not cloth or anything of that nature. And the amount of space that you need for this is very little. You can do this in a 6 by 6 foot room.
Wow. Is embedding care in workplaces and residential towers and mining towns, is this like the next frontier of outpatient quality improvement? I have to say I've never heard a presentation on this at any QI conferences, but it sounds pretty revolutionary.
But I think if you take a step back, I have a discharge summary from the early 1970s, and it was my father that was admitted. And he was admitted to hospital to manage his hypertension. And it wasn't severe hypertension. It wasn't life-threatening hypertension. It was just hypertension. And his cardiologist said, it's comical to read today, 50 years later or whatever. This man's wife is on vacation for 2 weeks, so I've admitted him to hospital so we can address his hypertension. We've come a long way since then. The stuff that we admitted people to the hospital for now is much, much, much more severe, and rightfully so. And the consequence of that is that the stuff that is less severe than that, we need to not take care of in a hospital. We cannot be doing routine. I have a hospital-based clinic and I feel bad about it because I see some mild asthma there. I shouldn't be seeing mild asthma in a hospital. It's way too expensive a place to see us. So I think as things that are less acute, subacute, and subacute are being pushed out to the ambulatory space, it's only a natural extension that some of that stuff that was traditionally in an ambulatory space is being pushed into the community. Whether that'll be in people's homes, whether that'll be in people's workplace, whether that'll be people's schools, whether that'll be people's neighborhoods. Could there be a kiosk on the corner of your neighborhood, where you could get your checkup? I think that's the way of the future, especially as blood diagnostics become more efficient, and you can just prick your finger and get a whole bunch of that information. Obviously, we have to make sure that that's all legitimate and meets standards of care and is cross-referenced with gold standards and things like that. But I honestly think there'll be a day very soon where you will not leave your house to get your annual physical exam.
Yeah, so it's as if you anticipated my next question, because I'm really interested in how you're talking about these innovative ideas. And I wonder, if we fast forward 5 or 10 years, what do you think will surprise us about routine outpatient visits? What will outpatient visits look like?
I think that the foundational information about yourself, so your sort of your biohacking information that everyone's after, will be easily attainable by yourself and in your home, right? Whether it's wearable technology, whether it's something like TytoCare where you're gathering that information. I think that baseline stuff is going to be there. I think what's going to happen is that the only reason you would go to see someone in an office, one is if you need advanced diagnostic imaging. So I don't think you're going to have an MRI machine in the corner of your neighborhood. I think that's something you're going to have to go to in to see someone. Minor procedures, obviously, you're going to have to go in for if you need a mole removed and whatnot. Vaccinations, I can't see a day where you're self-administering vaccinations, unless, of course, they're intranasal, and who knows, maybe we can do that. But there'll still be a role for those type of intervention or procedure-based visits. But short of that, I would say 75% of the stuff that we have people come to the office to get done, prescription renewals, education on diabetes, et cetera, et cetera, et cetera. I don't think people will be coming to the office to do that anymore. If you look at every other industry, and as you know, Jason, unfortunately, medicine is usually lagging about 20 years behind every other industry. But if you look at the banking industry, you don't go to the bank anymore. Everyone does online banking. You want to, cash a check, you're doing that and online, deposit a check, and transfer money, pay your mortgage. And none of that is done in the actual facility anymore. And healthcare eventually will follow. Whether it'll be 5, 10, 15, 20 years from now, who knows? I think we're still using faxes, right? So go figure.
Faxes and pagers.
Faxes and pagers, right?
Yeah. Well, I think that's a great place to end our conversation. I really appreciate this. And I think that gives me and hopefully some others a lot of food for thought on what's coming down the pipe in innovative outpatient care and even in areas that we don't even think about as being outpatient care, right? In these whole new kind of clinic models that you're describing and, health advisory within the workplace. And so really appreciate, Khalil, you taking the time to have a chat with me today. And really appreciate you.
Thank you. Thank you very much, Jason.
For listeners who'd like to follow your work and or get in contact with you, where should they go?
Well, if they're on the Canadian side of the border, they could look up Cleveland Clinic Canada, and all of our contact information is there. Otherwise, I guess they would contact you to contact me.
Sounds good. So we'll link your profile in the show notes. And thanks so much for sharing your insights on quality improvement, measuring metrics that matter, and innovating new models of outpatient care. Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.